So I'm Kristen Ciomber. I'm one of the physicians at Vanderbilt University Medical Center in Nashville, Tennessee. I'm a GI oncologist, and I also do colorectal cancer research. ASCO this year had a lot of exciting takeaways, especially in colorectal cancer. So I think the takeaway from the plenary session was the results from the Paradigm phase 3 study looking at the addition of a biologic, whether it's panitumumab or bevacizumab, to the backbone FOLFOX chemotherapy in first-line RAS wild-type metastatic colorectal cancer. So we saw the addition of panitumumab increased efficacy, specifically median overall survival, when compared to the addition of bevacizumab. Then we saw the dynamic study, which was really looking at circulating tumor DNA guided adjuvant therapy decisions in patients who have had resected stage 2 colon cancer. So I think we're starting to learn that that is going to be a useful tool for us to figure out who needs chemotherapy and to optimize how we give chemotherapy to the right people. And finally, the third takeaway that I really focused on from ASCO this year, at least in the colorectal data, was in the PD-1 blockade in patients with MSI high or deficient mismatch repair locally advanced rectal cancer. So even though it was only 14 patients, we saw 100% clinical complete response rate after 6 months of dostarlimab. This was a single institution study, so we really need to follow this up with other studies like the ECOG ACRIN2201 and others, and we need longer follow-up, but it's a really exciting first step. So circulating tumor DNA testing in my patients in particular is a little bit tricky, and it does require a lot of discussion with patients to figure out who is eligible for it, in whom can it be helpful, and what are the limitations of testing. So at the current time, the good thing is that we have multiple prospectively enrolling clinical trials that Vanderbilt, for instance, is enrolling patients to. So I almost always will, if patients are eligible, will encourage participation in those clinical trials to help us get the best data possible that will help inform our practice later. Outside of a clinical trial, it really is a one-on-one discussion with the patients, and the anxiety level that the results can sort of bring about is something that really is an important thing to focus on. In some cases, I've actually had patients decline ctDNA testing because of that feature, especially since we know it is a prognostic test, but we don't completely understand the limitations of it as a predictive biomarker. And so in cases in which it might not change therapy, or we don't know what to do with the information, I really have a back and forth conversation with patients about whether that's the right test for them at that moment. So I think oncology is a field where we have a lot of data on medicines and diagnostics, but we don't necessarily have as much data as we would like in other fields, and that includes integrative medicine. So it really leaves us in a quandary when talking to patients, because many times they're asking questions about how to incorporate these things into their treatment, and sometimes we just don't know. So I do think that there is likely a role for them, but that is a very broad category, and so we really need to understand in an investigative way sort of how best to use that and in which patients. But I do think practitioners can be open-minded and understanding that perhaps the level of evidence that we have for some of these are not the same as we have for, say, chemotherapy. And so we have to understand the limitations and the potential advantages of that as well.